Good morning, everyone. Start. I am Dr. Bharath. I'm a consultant surgical oncologist at Fortis Cancer Institute, Bangalore. So today I'll be talking about increased prevalence of colorectal cancers in India. So colon and rectum are the terminal parts of the digestive system. They help in absorption of water and other nutrients, and also in the formation of stool and storage of stool. So there are different parts of the colorectum. So we can divide it into the right and the left half, or we can divide it into further subparts as ascending colon, transverse colon, descending colon, sigmoid colon, and then the rectum. So colorectal cancers are the third most commonest cancer in India. So that is why we need to be aware of colorectal cancers. Talking about the lifetime risk of colorectal cancers, it's around 1 in 23 men will be suffering from colorectal cancer during their lifetime, and in women it is 1 in 26. If I talk about the absolute number of colorectal cancers in India every year, around 65,000 to 70,000 cases of colorectal cancers are diagnosed every year in India. The difference between the colorectal cancer seen in India and the Western world is that in India, we see colorectal cancers in a younger age group, especially less than 50. 60% of our colorectal cancers are below this age group of 50. And we see more of left-sided tumors or rectal tumors. We see more of tumors in an advanced stage. This could be because of delay in presentation or delay in diagnosis and delay in treatment. Due to the advanced stage of the disease, we see a poor prognosis and more number of deaths in India. So I've already highlighted that colorectal cancer seen in India is more in the less than 50-year age group, and we see more colorectal cancers in men, and I already highlighted that it is more common in the left side of the colon. So colorectal cancers, the commonest type which happens is known as adenocarcinoma. It starts in the inner lining of the colon, which is known as the mucosa. Initially, they begin as polyps, and later on they might progress to become cancers. So talking about the risk factors of colorectal cancer, we can divide the risk factors into modifiable risk factors and non-modifiable risk factors. The modifiable risk factors include, so colorectal cancer is seen increasingly in people who smoke, who have a habit of alcohol consumption, whose diet is low in fruits and vegetables, that is low in fiber, and higher intake of fat and red meat. Also, higher intake of barbecued food also leads to increased incidence of colorectal cancers. Sedentary lifestyle, obesity are other modifiable risk factors. Talking about the non-modifiable risk factors, age is one of the important non-modifiable risk factor. So I already mentioned that with increasing age, we see a higher number of colorectal cancers. But in India, we are seeing colorectal cancers at a younger age group. In terms of the gender risk factor, males are more prone for colorectal cancers compared to females. And we see more of colorectal cancers in the northern part of India compared to the southern part of India. Family history of colorectal cancers could also increase the risk of developing colorectal cancer in an individual, especially if there are certain genetic mutations like familial adenomatosis polyposis and Lynch syndrome. These are some of the commonest genetic mutations which lead to an increased risk of colorectal cancer. Personal history of colonic cancer also or polyps also increases the risk of colorectal cancers, and inflammatory bowel diseases could also lead to a higher risk of colorectal cancers. So these are some of the non-modifiable risk factors of colorectal cancer. Now coming to the symptoms of colorectal cancer, there could be an alteration in bowel habit, there could be incomplete evacuation, blood in the stools, abdominal pain or cramps, weakness or fatigue, weight loss, especially unintentional or unexplained weight loss. These could be some of the commonest symptoms of colorectal cancer. Now, when I talk about the treatment for colorectal cancer, The treatment for colonic cancers is slightly different from the treatment of rectal cancers. For colonic cancers, the main modality of treatment for localized cancers is surgery. After surgery, based on the report, we will decide whether you need additional chemotherapy or not. In case of metastatic colonic cancers, the main modality of treatment is going to be chemotherapy, which is given with a palliative intent. Surgery has a very limited role only in cases of obstructing tumors or when there is bleeding from the tumor. When I talk about rectal cancers, the treatment is different because in rectal cancers, radiation also becomes an important modality of treatment. Most of the localized rectal cancers will receive some kind of radiation, either in the form of short course or long course radiation, along with chemotherapy before surgery. So once you are done with your radiation after a certain period of time, then you will be planned for a surgery. In the treatment for metastatic rectal cancers is mainly chemotherapy, and surgery and radiation have a limited role. Talking specifically about surgery for colorectal cancers, surgery involves removal of the tumor along with the margin and also removal of the lymph nodes. So removal of the lymph nodes or the regional lymph nodes becomes an important part of the surgery as well. If the surgery is not done well, then you might have an increased risk of the disease coming back. So it is very, very much essential that the lymph nodes also be removed as part of the surgery. So there are different ways of doing colorectal surgery. It could be a traditional open surgery or it could be a minimally invasive surgery. Most of the institutions nowadays have shifted to minimally invasive surgery, which is laparoscopy or robotic surgery. In our institute, our preference is to do laparoscopic surgery for most of the colonic cancers and upper rectal tumors. In case of lower rectal tumors, we would prefer a robotic surgery compared to a laparoscopic surgery. And there is sufficient evidence to establish the safety and efficacy of minimally invasive surgery in colorectal cancers in comparison to open surgery. So, and nowadays it's been told that minimally invasive surgery is superior compared to open surgery. In certain population of the lower rectal cancers, some centers even nowadays are doing abdominoperineal resection, which is a surgery wherein a patient will end up with a permanent stoma on the permanent stoma. So there are certain low rectal cancers which are feasible for certain types of sphincter sparing surgery like intersphincteric resection, wherein even though the tumor is in the lower portion of the rectum, we are still able to maintain the sphincter and maintain the natural passage of the patient for passing stools. So let us talk about the prevention of colorectal cancers. So when I talk about the prevention of colorectal cancers, I've already mentioned about the risk factors of colorectal cancer. So avoiding the risk factors itself is going to help in prevention of the colorectal cancers. So you should be avoiding smoking, you should be avoiding alcohol consumption. Your diet should have more of fruits and vegetables, lesser or restriction of the meat products, especially red meat, more physical activity and exercise, reducing your body weight and maintaining an optimal body weight. So these are the preventive measures for colorectal cancers. Now let us talk about screening for colorectal cancers. So in general, we tend to start screening for colorectal cancer starting at the age of 45 years. So for an individual with an average risk of colorectal cancer, this is the age at which we would want to start screening. For people who are at a higher risk because of their genetic risk factors or a family history of colorectal cancers, we might start screening at a younger age group as well. The different modalities of screening for colorectal cancer include colonoscopy, wherein we use a camera to look at the inside of the colon completely, or it could be a CT colonography, wherein a CT scan is done to look at the status of the colon. Compared to colonoscopy, CT colonoscopy is inferior in terms of the pickup rates. Then there is a sigmoidoscopy, wherein we look at the lower portion of the colon. We cannot look at the complete colon in a sigmoidoscopy. Some of the colorectal cancers in the initial phases also cause bleeding in the stools. So by detection of blood in the stools, we could also screen for colorectal cancer. These tests are known as fecal occult blood test or fecal immunochemical tests. So what is the recommendation for doing colorectal cancer? So I already mentioned in terms of age, it has to be started at the age of 45 years. And what is the guidelines recommend for the different types of screening modalities? So if you are doing a colonoscopy, it is supposed to be done once in every 10 years. If you are doing a sigmoidoscopy, it is supposed to be done once in 5 years, and a fecal occult blood test or a fecal immunochemical test every year. So a combination of sigmoidoscopy and fecal occult blood test is the ideal preferred modality of screening for colorectal cancers. You can use other CT scan and other modalities as well, but they are inferior compared to colonoscopy or sigmoidoscopy. So thank you very much for the patient listening. If there are any questions, I would take up the questions. So be aware of colorectal cancers, and if you are above the age of 45, get yourself screened for colorectal cancers. Thank you very much.